Uh, Good afternoon, ladies and gentlemen. We are going to start the next session, which is the most interesting one for the rest of the day, what we call complex and revisional surgery. And we have got fantastic 4 chairs. Mr. Simon Dexter, who is from UK, Mr. Mal Fobi from America, Dr. Manish Khaitan from India, and Dr. Manish Parikh from USA. I will leave the rest of the session with them. Thank you.
Well, good afternoon, and thank you Sanjay for inviting me to be part of this program. It's an excellent program, and I think this session, as you rightly say, is going to be exciting. We've got some real surgical heavyweights involved, and the first session, if I can get cut to the chase, will be on the preferred procedure for patients with a BMI of more than 50, and to talk through their various approaches, we've got Huang from Taiwan, the China Medical University Hospital. He's a very experienced surgeon who's brought in many innovations, and clearly will have some great opinions. Kamal Mahawar doesn't need any introduction to anyone here, I don't think. He's a surgeon from Sunderland who's of late brought in the tugs innovation amongst many other things, which is happening tomorrow. And then Pradeep, Chowbey and Natan Zundel, both past presidents of IFSO, and again, really looking forward to hearing your thoughts. So if we could, without further ado, step forward, Huang, to tell us your opinion. Thank you.
Okay, everybody can hear me?
Yes, we can hear you, CK. Go ahead.
Yes, I'm going to try to share my my PPT, but I think cannot upload right now. Can anybody can help me right now, or it's quite straight? Yes, I tried it, but I don't know why it cannot share.
That's okay. Yeah, Simon, when you give me the go ahead, I can start.
Yeah, please fire away. I think we'll let the
ladies and gentlemen and esteemed chairs, good afternoon. First of all, huge thank you to Sanjay for pulling it off. Really, LIBSS is his brainchild, and he's done exceptionally well with this meeting. I have to say, the talk that I've been assigned today is preferred operation for patients with BMI more than 50, role of OAGB in that context. I've been given 7 minutes. I'm hoping to finish before that. So I think I should go to the first slide. Many thanks, Simon, for your generous introduction. I'm a consultant surgeon at Sunderland and South Tyneside NHS Foundation Trust, and I'm a visiting professor at the University of Sunderland. I also work with some societies and journals, as colleagues might know. BMI more than 50 presents a special group of patients who are technically more difficult and have a bigger burden of disease. So, I think the language that we used to use in the past, super obesity, came from that background. And in the days of the open surgery, when we used to use OSMRS score to quantify or predict the risks of patients, it was actually component. BMI more than 50 was one of the scoring parameters. So we've recognized for quite some time that this is a special and challenging group of patients who need a special sort of intervention. If you look at the choices available for primary bariatric operations currently, they're largely, I think, the practice is confined to four, if not three procedures, which are sleeve gastrectomy, Roux-en-Y gastric bypass, one anastomosis gastric bypass, and gastric banding, if you want to include it, though I haven't performed a gastric band since 2011. Roux-en-Y gastric bypass, though it is the dominant operation in my practice and is dominant operation has been in my unit, is a technically demanding operation compared to OAGB and sleeve gastrectomy, and it has a longer learning curve. Sleeve gastrectomy, on the other hand, it does not give the same metabolic benefits that, for example, Roux-en-Y gastric bypass does, or even OAGB does in the longer term, and I'm hoping to show you some data. Alistair Sharples and I, we did a meta-analysis of 5-year outcomes of RCTs comparing sleeve gastrectomy and Roux-en-Y gastric bypass outcomes, and we found that Roux-en-Y gastric bypass patients did significantly better. And obviously, we know from the Omega trial that OAGB has non-inferior weight loss to Roux-en-Y gastric bypass and possibly superior weight loss outcomes. So some data here, there's no head-to-head comparison between OAGB and Roux-en-Y and sleeve in this cohort in a randomized study. But I've got some data here to show you. So if you look at it, this is a patient's more than BMI 50 comparison of OAGB versus sleeve. And you can see quite clear excess weight loss difference of 56 versus 75 between the two arms. Another study, long-term efficacy of different procedures, and you can see all three procedures compared here, and once again, OAGB stands out. And this is the same trend we found also. We did a large study of more than 10,000 patients in longer-term outcomes in an Indian study led by my good friend Sarfaraz Beg and colleagues, and the outcomes and the data was similar, but that was not just concentrating on patients with BMI more than 50. Another study, and the outcomes are similar. If you look at it, OAGB tends to perform better than sleeve gastrectomy in patients who suffer from BMI more than 50. There are more studies. I could go on. We have published 2 studies from our own center in Sunderland, but they were focusing on BMI more than 60. Take it this way, very few surgeons in Sunderland would do anything else other than OAGB for BMI more than 60. And if I say most of the BMI more than 50 patients also will get OAGB in our unit. That has become almost the default. This is the Omega trial. As I was saying earlier, we know what was very publicized from the Omega trial, some of the key things, that the weight loss is non-inferior. But obviously, this trial also showed higher nutritional complications with OAGB because surgeons were using 200 centimeters B-prelim. And as a result of that, this procedure got banned in France. I just want to use this opportunity to highlight to you that what was the learning curve of these surgeons in OAGB, that they do 200 odd operations and they have bowel injury in 2 and they staple the orogastric tube. I'm presuming they wrote nasogastric, but I'm presuming it is an orogastric tube in 2 operations. That tells you what is the learning curve of these surgeons who were doing OAGB in a large state-funded RCT, which led to banning of a procedure in that country. I don't need to say any more. I want to highlight also the early complications rate. Even with that learning curve, you will see that OAGB had almost half the 30-day complication rate compared to RYGB in that study. I should point out, this is not just a study of BMI more than 50 patients. They had all patients qualifying for surgery. But what I'm trying to say here is that RYGB has a higher complication rate than OAGB, and I'm supporting that with some randomized data. I think I've taken 6 minutes. In conclusion, ladies and gentlemen, my bias and my feeling and my conclusion is that OAGB offers the optimum balance of safety and efficacy for patients with advanced obesity and is currently my preferred approach for these patients. Thank you very much for giving me the opportunity to talk to you. I will have to leave early, but I will try and stay for this session to answer my questions, if any. Thank you.
Good, thank you, Kamal. That's a great start to things. I think probably a sensible thing would be run through the presentations, then we can have discussion at the end. Is Chikun ready with his slides yet? If not, we could perhaps move on. Pradeep, perhaps you're available to give your talk. Would that be okay?
Yeah, sure.
Well, an absolute pleasure then. Let's
Yeah.
pass the pass the floor
will
over
share.
to you while the technical guys do their wizardry in the background. Thank you.
So I hope you are able to see the slide there.
Yeah,
The slide you can see.
we can. Yeah.
Yeah. Okay. So good evening, everybody. Thank you so much once again, for giving me this an opportunity to present this. I think we also would like to express that we have been one of those very staunch follower of Roux-en-Y gastric bypass. Thanks to Mal, who visited us almost 20 years back, and we got impressed, and over a period of time we realized that this is something which has to be properly learned and should be provide the benefit to the patients. Today we are talking about the super obesity, and we always believe, and still this coin is very popular with me, that every time there are two sides of the coin, and here we are talking about the comorbidities, and especially when we talk about the comorbidities, I think Indian and South Asia and Asian subcontinent is very special, because we have a lot of associated metabolic syndrome in majority of these patients. So whatever surgery we are doing, I think we should keep in mind the metabolic aspect of the bariatric this thing. We all know the history. It's a long history of gastric bypass, starting from 1967, when we talk about Dr. Masson, and then also we have in 1994 when we started laparoscopic the bariatric surgery, and we should be really giving a lot of credit to our senior colleagues who started this to be done laparoscopically. Of course, Mal is here, and as I mentioned, that Mal taught us how to do gastric bypass, and of course he added a ring on that. So we are talking about the gastric bypass with or without restriction. So I think I would just like to say that gastric bypass, some of the very important factors we all know, but just I would like to re-emphasize that the good results of gastric bypass in super obese patients will come on depending on the small pouch, the size of the pouch, the micro pouch. You have to be particularly careful about the size of the pouch, because sometimes with the technical difficulties, we land up with a longer pouches, and also create may not get as good outcome as we expect. And then we talk about our great academician who believes in publishing, Kamal. He has just spoken to discussed his paper. I think, like we should be aiming to bypass at least 100 centimeter of jejunum to achieve the most benefit out of gastric bypass. It's a well-documented, evidence-based. So, and of course, the measuring should be more accurate, more proper, and more than 200 centimeter of a small wall should be sort of bypassed to improve the weight loss predictably. And all these things are more specific to the super obese patients rather than the other group of patients, though it is important for all groups. The stoma, I think we all know that the three types of stoma. In our experience, we are doing the circular anastomosis using the staplers. But I would like to emphasize that if we are really looking for a micro pouch, this circular anastomosis really gives us a very, very strong technical advantage of having a micro pouch and very well measured micro pouch. Other modalities, I think everybody is doing and having a good result. But I think certain papers, as you see here, these publications, the sleeve gastrectomy is, initial period, it may be a good operation, but sometimes later it starts showing up and the weight regain is there. In Indian subcontinent, BPD, DS, and maybe even single loop bypass may present with the nutritional deficiency over a long term and many years after the operation because of the predominantly vegetarian diet which the Indians follow. And in our experience of last 20 years in India, I think we feel that the RYGB gives the perfect balance between malnutrition and the weight loss. So based on the result, I think, this another publication, there are 3 publications which we are talking about. And this is one publication which again says the gastric bypass, the significantly higher percentage of weight loss and as compared to the sleeve. Then the Michel Suitors, again, this says equivalent improvements of quality of life and obesity-related comorbidity index. Weight loss is not all that matters after bariatric surgery. It is the metabolic issues which are say. And I think we just talked about the complications in our series and our experience. If you do well-trained surgeons in the team, the RYGB is a fairly safe operation with minimal problems in the post-operative period. And just to emphasize that it is not, the gastric bypass is not only good, this is our patient which created a world record of a teenager whose BMI was 95, and we could successfully do the gastric bypass in such patients. So this is what I would like to conclude, that too much restriction or too much malabsorption, I think it's a question of balancing it. And I very strongly feel, and also the evidence suggests that gastric bypass may be doing that balancing act. And this is what exactly I would say, that it possibly is going to remain in future also the standard bariatric surgical procedures. And my greetings from the institute, Max Institute at New Delhi. Thank you very much for this opportunity.
Sorry, thank you, Pradeep. I'm just unmuting myself. Yeah, that's a nice, thoughtful review of RYGB. Now, I think we've got everybody else here now. So if we can move back to Chikun Huang, who's now ready to go with his slides.
Yes. Okay. Sorry for the mistake of the computer. I'm going to talk about sleeve gastrectomy is preferred for super obesity. Next one. Today is Thanksgiving Day, so this is the turkey that we sacrificed today. Thank you. Next one, please. I would say super obesity is a different disease compared with morbid obesity. Have several studies showing that the super obese patient get more risk of intra and the post-operative complication, and surgical time is longer and hospitalization is longer too. Next one. And the super obese patients are increasing a lot. And as you shown that the lifespan is much decreased as the BMI going higher. So when the BMI achieves the 50, then the lifespan decreased about 10 years. When more than 55 is less than is more than 13 years less in the lifespan. So we have to save these kind of patients as we can. Next one. So in American Society position statement, they have recognized the sleeve as an acceptable option for those with high-risk patient as a planned or stage operation is the choice. So with many the other operations, long-term weight regain can occur, like sleeve, even bypass or RYGB has the same problems, need a re-intervention. Next one. So for the super obesity patient, overall risk, you can see in the obesity surgery mortality risk scores, the BMI more than 50 become the 1 point. For those with higher points or higher scores, then the patient increase the risk of mortality risk. Next one. So I'm going to show you some meta-analysis that has been published in the papers for the sleeve versus Roux-en-Y bypass. Next. Roux-en-Y bypass and sleeve. In fact, this study, including 54,000 cases, is quite large numbers of the meta-analysis. Bypass has longer operation times, but in the length of stay is similar. There's no difference in the complication, including leak or mortality rates, and has higher weight loss for the sleeve for the bypass cases at 2 years and 3 years. And the bypass seems to have achieved a better control of diabetes and dyslipidemia. Okay, it's the only thing that we can see. Next. In another meta-analysis that we can see for the bypass and the reef and the sleeve, the bypass has better weight loss outcomes, dyslipidemia resolution, and reflux, but there's no other significant difference in the remaining comorbidities. The technical simplicity and the chance of the toward unsuccessful weight loss that need a revisional surgery more favor sleeve gastrectomy surgeries. So next one. So how about the perioperative safety? Can we go back? Yes, next one. I think for the super obesity, perioperative complication is what we really concerned about. Complication and mortality rates within 30 days were compared between different groups. In these papers, that is from the national base of the American Society, including morbid obesity and super obesity and super obesity groups. Next one. So you will see, could you go into next one? Yes, you will see for the morbid obesity one and super obesity and super these three groups in sleeve and bypass, all of them showing that loss when the BMI going higher, the conversion to open is more. The length of stay is longer, operation time is also longer. And compare with the Roux-en-Y bypass and the sleeve gastrectomy, you will see the conversion to open is higher in the Roux-en-Y bypass. And the length of stay and also operation time is also longer compared with the sleeve gastrectomy. Next one. And very interesting is for the complications, Roux-en-Y bypass carry more complication rates and even mortality when you're doing in the super obesity and super obesity, if you compare with sleeve gastrectomy. So I think in perioperative complications in this study, you will see sleeve is better than the Roux-en-Y bypass. Next. How about in Asia? This new paper was published in Taiwan. This compares sleeve, Roux-en-Y bypass, and the OAGB. Next. This is the 10 years results studies from the retrospective analysis, and this is from Wei-Jie Li's group. The results showing that totally there's 3 groups of operation. They do retrospective study for that. Next. So for the weight loss, seems OAGB is better than the Roux-en-Y bypass and better than the sleeve, but the difference is not much. Next. But the complications overall, you will see in the sleeve is 3.1%. Roux-en-Y bypass is 17.7%. OAGB is 8.5%. Sleeve on less perioperative complication rate compared with Roux-en-Y bypass and OAGB, no matter it's minor or major complication. Next one. Another most important thing is that the long-term revisional rates compared with OAGB and Roux-en-Y bypass. You will see sleeve only 2.6%, Roux-en-Y bypass 8%, OAGB 6.9%. Mostly the common reason for revision is because of malnutrition, anemia, bioreflux issues in the Roux-en-Y bypass and OAGB. Next. So my conclusion here, I think bariatric surgery for super obesity patients carry more risk and complication when comparing with non-super obese patients. Roux-en-Y bypass and OAGB seems to have a better, a little better weight loss results, but not really in the comorbidity remissions, but also higher in the long-term revisional rates in our Asia reports. If you consider surgical complexity and complications, I think sleeve definitely become a better choice for surgeons in choice, even before we take nutritional complication into account. So this is my presentation. Thank you.
Yeah, thanks very much. That's a good counterpoint view, and I think we're going to come back to discuss that. But before we do, Natan Zundel is hopefully with us now and able to give his perspective. He has been on the screen. Are we there? Yes or no? Okay, well, perhaps while we're waiting for him to log on, we could perhaps start some of the discussion. And I think, to me, it seems that some of the issues here, the technical difficulties associated with operating on these large patients, and then the longer term issues. The technical difficulties, I think you alluded to it there in the last presentation, that, you know, is BMI 50 really a reasonable cutoff? And I think both Kamal and Chik and Huang there alluded to the fact that it's probably somewhere in the mid-60s you start really predictably getting into problems. And central obesity, I guess, is the other issue. And should we be treating those groups differently rather than the BMI 50 plus group, which are fairly commonplace and technically not terribly difficult? And I guess the other issue then is the other thing that keeps raising its head in these discussions is nutritional issues and malabsorption. And my own perspective, I don't know if that's shared with the others, is that, you know, if you start taking patients with the real super obesity, 65, 70 plus, then, you know, there may be patients who you start to select groups of people who are likely to be less compliant and less able to look after their nutritional issues. And perhaps we should be more careful rather than more free with using more malabsorptive procedures. I don't know what your thoughts are, if we could put that out to the panel.
Welcome, Simon. I was going to say thank you, Simon. I think your point with regards to the BMI cutoff is valid, Simon. I think historically BMI more than 50 has been a cutoff which has been used in many areas, but it no longer indicates the patient population that I think we were trying to address in this session. Really, BMI more than 60 certainly, I think, and some patients in BMI 50 with a more central predisposition to obesity. But those patients where we are expecting difficulty or where we think there's going to be challenge here, we would generally do OAGB in our unit. And I think that with regards to long-term nutritional issues, none of us use more than 150 centimeters per limb. I'm increasingly using 100 centimeters. And we see malnutrition, but it's like, 1 in 400. So it's very rare, So that's the data, that I can share with you.
Yeah, good. I did a OAGB on a girl with a BMI of 104 on Monday, so and it was actually quite straightforward. So yes, yeah. Anyone else?
Well, I still feel that the complication rates which have been shown in the presentation, CK presented that of almost about 17% for gastric bypass looks quite steep, because I think, for at least for 20 years, we have not really felt that way, that higher BMIs, the chances of complications are more. I think it's a matter of technique and adopting the technique and the team which works. And I still feel that even the complications of gastric bypass, maybe leak or maybe bleed, are far simpler and better and effectively handled as compared to the sleeve complications and MGB complications, And especially I'm talking about the Indian subcontinent, as I mentioned again and again, that very difficult to follow these patients. So they might gain a little weight, they are better off, rather than with a malnutrition, which is quite difficult and expensive way of handling such patients.
Yeah, so stick to what you're good at is what you're saying.
I have a question, Dr. Kamal. If you can speak, you have been advocating a BP limb of 100 to 150. I personally also feel a long BP limb in OAGB give a lot of malnutrition, but then what about the weight loss? Because we are talking of BMI 50 and plus. So do you think your able to achieve a weight loss of near 25 to 30 BM?
So Manish, I think that is a profound question. Thank you for asking. So with regards to somebody's microphone needs to be muted. With regards to the weight loss, we have done a head-to-head comparison of BP limb of 150 centimeters and 200 centimeters in our unit at 18 to 24 months. And we found no statistically significant difference between the two groups, even though the BMI more than 200 patients, BMI 200, BP limb 200 patients were heavier. They hence expected to lose more weight, because they by in kilograms they lose more. And also in terms of the efficacy, now there are at least 5 or 6 papers. There's a paper by Liagre et al., 8 years data on OAGB 150 centimeters. So I think the data is coming and it's there. It's the Roux-en-Y literature, which Professor Chowbey quoted our systematic review published 5 years ago. People have been using all kinds of limb lengths in Roux-en-Y literature. I looked at every single paper 5 years ago, and since then, people have done every limb length you can possibly imagine and found no significant difference. And that's how we came down to 50 BP limb and 100 centimeters elementary limb or 150 centimeters elementary limb. That journey was not without our own learning curve. I think OAGB surgeons are doing the same. They're experimenting with longer and longer limb lengths, believing that will improve outcomes, but it doesn't. All it does is increases complication rates, as Manish pointed out, and increases the malnutrition rates.
So then I have a question for the group. Is there anyone then that you would stage with the sleeve? Because it sounds like even BMI 60, 90, you're doing either Roux-en-Y or one anastomosis. So it sounds like, is there a role for staging with the sleeve in any of these patients?
We wouldn't, Manish, we are not funded routinely to have a second procedure. We try to give a one-stop answer to the patients. Funding is a real issue in our setup. We try to do an OAGB, and that generally works for most patients.
Yeah, I think it's an interesting question, and it, of course, is a planned stage procedure, or are you doing a sleeve in the anticipation if they regain it's an easier or more versatile operation going forward to convert to other procedures? We looked some time ago, we looked at using in BMI 65 plus patients a sleeve as a stepping stone towards a DS, and only about half the patients went on and had a second stage because the other half did well and were happy with the outcomes. And I think therein begs the question of what we're trying to achieve. The statistical differences on paper between the sleeve and the bypass or an OAGB, if you reflect that onto a patient, you may see, a potential difference of, 5 or 10 kilograms, depending on their starting weight, for example. Realistically, what impact, how relevant is that difference? The patients want to lose as much weight as possible, but we're about trying to impact comorbidities, and, which would, that argument, I guess, would support your contention, Chikun, that the sleeve, even though you don't achieve quite the same outcomes, may be simpler, more straightforward, and really get the hump of comorbidities down, which is what we're trying to achieve. The point, though, then is if I go back to Pradeep, is the sleeve safer than a bypass if the bypass is the procedure that you do day in, day out? And certainly sleeve leaks are a major issue to deal with if you get them. But I guess if you do enough, you can get that leak rate down.
I have a question to ask to all panelists. With a BMI of 50, obviously the patient is coming to you for a weight loss and resolution of comorbidities. Suppose the weight loss is not as per the expectation, as per your expectations. So do you explain during first consultation about a second procedure, you have done a sleeve or OAGB or a gastric bypass? So I have a question from Dr. Chowbey, Dr. Kamal, as well as Dr. Huang. Okay. Do you explain if the patient is not going to have a weight loss, what is the plan of action, next plan of action?
Well, I think if you ask me, all the procedures are important for weight loss, but it all depends on the compliance. I think, if the compliant patient is not the candidate, I think his expectation should also be Chais, I think we should not give them a super unachievable expectations. I think that is what is very important, and they should be pre-warned also that if they do not comply, the results may not be as good as they are expecting. And preparing them mentally is more important than discussing about the details about a particular procedure, pros and cons, because that generally confuses the patient more than anything else. And as we know, our younger generation also is very confused where to do and what to do. And we have got dozens of procedures which are there, and everybody says that that particular procedure gives the best outcome. So you have to see what is your strength, which can do a safe surgery with a reasonably good outcome. And I give lots and lots of importance to the quality of life more than the quantity of weight loss.
Okay. About these questions, when I face the patient, I always tell them that the 3 goals of bariatric surgery for them. The first is the patient should achieve ideal body weight, the best one. The second is remission of the comorbidities. Third one is better quality of life after surgery compared with before. So how we choose the procedure for the patient. In fact, for myself, I also did not only do sleep or bypass, I also do sleep plus procedures. But according to the patient's expectation, his comorbidities, and right now the GI conditions, we would decide a better choice for them. And of course, we talk to the patient about his expectation. Some female younger one, they want a good weight loss. They don't care about the comorbidity. They don't care about what the quality of life. But for the older one, the diabetes metabolic surgery patient, they have different expectation. They want the diabetes remission, but they don't want very much weight loss. So I think that we still need to consider about the quality of life. The quality of life is part of the expectation of patient. So to talk with the patient and family thoroughly, I think it's important for me.
Yeah, I think as you probably gathered, Natan Zundel couldn't join us, so it's given us a good opportunity for this discussion. We've only got a couple of minutes left. There was a question actually came through the chat line about OAGB versus Roux-en-Y for resolution of comorbidities, particularly diabetes. Is there an opinion on if one is better than the other, if there is, and why that should be in this group? Kamal?
Yeah, Simon. So there's no head-to-head RCT looking at the diabetes outcomes comparing the two. However, if you look at the subgroup analysis from the Omega study, there was a perceptible and clear difference in diabetes outcomes between the Roux-en-Y gastric bypass and OAGB group. I think the resolution rates were almost double in the OAGB group. And if you ask me why that is the case, I think it's just the absence of Roux-en-Y, because Professor Himpens has shown in his study that removing the Roux-en-Y, it increases the incretin effect. And somehow that just leads to more metabolic benefit. So there's data to support higher diabetes benefit, and there's also a hypothesis to support that.
And presumably someone's going to be looking into that. That sounds like a fascinating area of study anyway.
I mean, with diabetes endpoint, there's only one RCT that I remember, it was published, I think, Roux-en-Y versus sleeve. That was the only, it is the Isoberg or some study, so Scandinavian, I think, RCT. That is the only RCT in bariatric literature where we had diabetes endpoint, apart from the Stampede, obviously, which had, all the two procedures, RYGB sleeve and also the medical arm, So there are very few studies looking at diabetes as the endpoint. And that is a problem, because they need more patients, really.
Right, we're going to wrap up. I think it's been a really interesting session. Thanks for all of your input there. Yeah, I think there's certainly an overwhelming notion of get good at something and do what you're good at, and then tweak it according to the discussions. So thanks very much indeed, everybody. And I'll hand the chair over to Mal Fobi.
Hello, thank you very much. And thanks, Sanjay, for inviting us to this next session. I'll go right to the speakers. Is Rudolph online? Dr. Weiner?
He's given us a video and he will join us online for discussion, man.
Okay, can we start with him? Dr. Rudolph from Frankfurt. Well, he doesn't need any further introduction. Go ahead and play his video. He's talking about re-sleeve for weight regain after sleeve gastrectomy.
Gentlemen, my topic is a strategy for managing weight regain.
Is the back office with us?
Sleeve gastrectomy, the re-sleeve. So I thank you, Sanjay, for selecting this topic. We can see now my IFSO case mix disclosure. I have no disclosure, but this is just for the surgeries, no relationship to any companies. And you see, I have done many of the procedures, and since 2001, also the sleeve gastrectomy and nearly all other procedures that you can perform. The perfect sleeve gastrectomy in this book from Michel Garnier, with many chapters, shows us how to perform the sleeve and what can happen in the long-term run. And we know that weight regain and also reflux disease can happen after sleeve gastrectomy. And we know, as a long discussion, what is the best technique to perform the sleeve to achieve the best results. We have many consensus conferences, and there was a discussion where we can start, what is the diameter of the calibration tube. And at the end point, we see that some patient will regain weight in the mid and long term. There's a classic indication. This is a mistake during the primary procedure. If the fundus was left in place, you see on the left side, or the fundus was migrated during or before the surgery, or the sleeve itself migrated later. This can be done, corrected by a re-sleeve. The same is and this is the most common problem, if you have a longer distance from the pylorus and the starting point of resection, the antrum became a new reservoir. And in this case here, you see it's about nearly 300 cc in total. And in this case, you can offer the re-sleeve gastrectomy as an option to initiate a new weight regain. And this can be successful, independent from the results in respect to the flux. We know there's a wide difference individual of the gastric volume, of the size. And if you have a resected remnant stomach or the sleeve resection done, then we can measure the volume, but we have resected, and there's a wide range. If you have only just 560 cc in the left corner up, you see that the stomach was from the beginning, maybe small volume, not a large fundus. And on the other side, you see in the middle, as a stomach was resected, a volume of more than 3 liters, 3,000 cc. And this will be maybe a very successful candidate for the weight loss after this procedure. But the most common problem is the antrum dilatation. You see on the left side, the starting point of 5 centimeters from the pylorus 4 days after surgery. You see a smaller antrum volume around 60 cc, but the same patient 8 years later has nearly 200 cc. And this can be also a candidate to perform a sleeve gastrectomy. Another situation is if the pylorus is not closing, it's always open, and the reservoir extended by the volume of the duodenum. In this case, the re-sleeve will be not successful, and he cannot a starting point for new weight loss. So we have many papers. I can show you a number of publications, mostly it is a smaller series. Therefore, in SORT was published last year a meta-analysis, a systematic review about all reported sleeve gastrectomies, 10 studies with more than 300 patients. And you see that there's a little bit an increase of the complication rate. The leak rate over 2%. It's much higher when in the primary sleeve, and the overall complication rate increased up to nearly 8%. But the estimated pooled mean percentage of excess weight loss was over 60%, and this is pretty good after a primary procedure. On the other hand, also the mortality range here in the reports in series from 0 up to 2.2%, and we concluded that the re-sleeve gastrectomy after a failed sleeve gastrectomy seems feasible and safe with acceptable positive leak rate, overall complication and mortality. But these are results on the short term, and we need further studies to see the long-term effects, maybe also the effect on the re-sleeve on the quality of life of the post-operative gastroesophageal reflux disease and the long-term weight loss. Thank you very much for your attention.
Thank you, Dr. Weiner. We'll move on to the next speaker, Dr. Ricardo Cohen from Brazil, who will talk to us about weight regain after sleeve, converting to Roux-en-Y gastric bypass.
Hi, Mo. Good to see you. Good to see everybody. Thank you very much, Sanjay, for the kind invitation. And I'm sharing my screen right now. I'll briefly speak to you guys about converting a sleeve gastrectomy into Roux-en-Y gastric bypass. Those are my disclosures regarding these presentations. I got no disclosures, no conflicts of interest within the next with this presentation. So the sleeve gastrectomies are increasing, the numbers throughout the world, not in Brazil at all, but throughout the world. We're still a bypass country. But I'm puzzled because it's not an easier operation, and it carries the same leak rate and same mortality compared to Roux-en-Y gastric bypass. Where did I take this information? If you look at level 1 evidence, the 4 studies in the screen, level 1 evidence, Roux-en-Y gastric bypass was as safe as a sleeve gastrectomy. And if you look at a huge meta-analysis published a few years ago, 11,000 bypasses and almost 5,000 vertical gastrectomies, what we can see here that regarding leak rate in the left side of the screen or mortality, there's no statistical difference between 2 operations. We can discuss further on why some retrospective and prospective studies shows that sleeves are safer. So it's a drawback of those studies. And it does not have a superior weight loss. This is 12 months weight loss, where the bypass is much better than the sleeve gastrectomy. Weight loss is not durable. This is a retrospective study published a few years ago by the Cleveland Clinic group that they showed that the Roux-en-Y gastric bypass is much more effective than the laparoscopic sleeve gastrectomy. The same as a metabolic procedure. If you look at the long-term effects regarding A1C changes, the sleeve is much less effective than the Roux-en-Y gastric bypass. And the Stampede trial showed that at 5 years, patients with, although that study was not powered to prove differences between the techniques, the Roux-en-Y gastric bypass used 4 times less anti-diabetes medications and cardiovascular medications in the bypass group. And the final thing, that's a close relation to weight regain and insufficient weight loss, that the sleeve is probably a cause of GERD and rarely improves gastroesophageal reflux disease. So revisional surgery here, Sanjay asked me to speak about weight recurrence, weight regain, and insufficient weight loss, and I'll show one slide about diabetes recurrence after a sleeve gastrectomy. So what we have here is that this was published 2 months ago, that in this meta-analysis, 30% of all sleeve gastrectomies will undergo revision at some time after the operation. And 80% of them, 80% of the revisions will go secondary to reflux, weight regain, or insufficient weight loss. There's a mix of insufficient weight loss and weight regain in the paper, so it's hard to differentiate which is which, but 30% of them will undergo revision. And there is a very strong association, it's not cause and effect, but a strong association between reflux and weight regain. And I believe that the Roux-en-Y gastric bypass has the best risk benefit when I think on converting a sleeve into a bypass. Better weight loss and reflux outcomes than re-sleeve. I can understand why repeating a sleeve when the primary one failed. And we have better nutritional outcomes than a DS, SADIS, or one anastomosis gastric bypass. There are some examples. This is a paper from Gerhard Prager group, where they show that converting a sleeve into a Roux-en-Y gastric bypass, good for the weight loss after converting, around 25% of total body weight loss and 100% of reflux resolution. A study by Salman Al-Sabah, where he showed that at 12 months, he compared re-sleeve and the gastric bypass. There's significant better weight loss after the Roux-en-Y gastric bypass when comparing to the re-sleeve. And this was published by the Strasbourg group. It's interesting to see here in the left side of the screen when you have here the sleeve, the BMI evolution of the sleeve gastrectomy with reflux complications and failure to lose weight. If you see here the green and the red lines, we show up to 5 years of follow-up, a trend to increase weight associated to reflux complications. And when they converted the sleeve into a Roux-en-Y gastric bypass, it's interesting to see that there's a steep decrease in GERD symptoms and good excess weight loss since the Roux-en-Y gastric bypass followed for 5 years as well. A touch on reoperations for the treatment of type 2 diabetes recurrence. This is a narrative review that we did with the Cleveland Clinic group. What we can see here, if we do something, if we convert a sleeve into Roux-en-Y gastric bypass because of diabetes recurrence and weight regain, I don't have time to show here, but if you look at the first two studies, there's 50% improvement and remission, 75% improvement and remission, converting the sleeve gastrectomy after to a Roux-en-Y gastric bypass. And we had some questions in that reviews. The first one, does revision helps diabetes status and other metabolic diseases like hypertension and lipid disorders? Mostly yes. And do we see anti-diabetic effects that are weight loss independent showing up after converting the sleeve into a Roux-en-Y gastric bypass? Yes, mainly those that come from gastric banding and sleeve gastrectomy into a Roux-en-Y gastric bypass. And if we have patients with persistent type 2 diabetes, not a recurrent type 2 diabetes, with inadequate weight loss, I believe after this narrative review that putting patients to lose weight through more powerful operations, yes, we can revert diabetes and get obesity into remission as well. Some technical considerations, converting the sleeve into a gastric bypass. It's a straightforward procedure. We're dealing with a small gastric tube. We go usually 5 to 6 centimeters distal to the GE junction. And we keep in mind that we're managing a small caliber gastric pouch. If it's a very tight sleeve, maybe you have to do a different way, the gastroject anastomosis. Sometimes there are a lot of adhesions. I just revised one this morning. A lot of adhesions between the left lobe and the staple line and the omentum. So it's a revisional operation. So go slowly and careful and things may go well. Our experience, we have 232 cases, follow-up 6 months to 12 years. And if we pay attention here to weight regain, we have 81 patients with weight regain, 7 with insufficient weight loss that we define less than 10% of total body weight loss at 1 year after the sleeve. And from follow-ups, the mean follow-up here is 5.4 years, 5.5 years. Patients could achieve 29% of total body weight loss over the revision, the pre-revision weight. And for insufficient weight loss, patients lost 25% of total body weight loss over the pre-revision weight. So Sleeve to Roux-en-Y. I believe that revision after sleeves are growing and will skyrocket very soon. We see monthly 4 or 5 cases per month here in our service. I believe that the Roux-en-Y gastric bypass so far has the best risk profile when revising a failed sleeve gastrectomy. And conversion into Roux-en-Y gastric bypass, it's a relatively straightforward operation. It's safe, effective, and a redo procedure after a failed sleeve. Thank you very much.
Thank you very much, Ricardo. Nice presentation. And our next speaker is going to be Almino Ramos from Brazil also, who will be talking about conversion to a one anastomosis gastric bypass. Almino, up to you. Is he in the house?
Almino is not here, I think, so Antonio will be going next, Kamal.
Okay. Professor Torres from Madrid, are you in the house?
Yeah, I'm in house. Mal.
Okay, let's find out what you do with the fill sleeve.
Can you hear me?
Yes, I can hear you. Go ahead.
Okay, let me start share my screen, and okay, I hope you can see now my slide. Can you? Okay, perfect. So my topic is going to be the strategy for weight regain after this Madrid convert to SADIS procedure. Okay, well, this is going to be my topic today, basically my disclosure. I mean, disclosure going to be here. You can see how I can, show you that we perform 42% sleeve and the same percentage of SADIS procedure and Roux-en-Y gastric bypass. We now are increasing our revisional rate, approximately 12 to 15%. There is no doubt that due to the pandemic sleeve, like a COVID-19 pandemic, going to be almost 60% in the SMBS and all over the world. In some countries, going to be even higher, this incidence. So some of them, as you can see here, the problem is some of them will for sure fail. There is no bariatric procedure that can, maintain the weight loss forever, and some, especially sleeve, going to be a problem with the weight regain. After, the primary surgery, the clinical approach and the management gonna be, to try to, we can have, expensive, excessive weight loss, but the majority of the patient under the sleeve is gonna be insufficient weight loss, less than 50% or said weight loss. So to face with this problem that the weight regain, the number is gonna be approximately between the very wide range between 5 and 40%, following the different paper published until now. And the first thing we have to do after weight regain, after sleeve of any procedure, is to evaluate properly the patient. Was the primary operation the best option regarding the patient's BMI, metabolic profile, the patient or surgeon choice, what the operation performed optimally regarding the bougie size, twisting, and so on and so on. And then after we have evaluated the patient properly, we can offer the patient nothing, or we can, I think it's very important to improve the compliance on the patient regarding modification of their behavior, the dietary modification, the exercise promotion, and so on. And even now, the role of medication is going to be increasing as the time goes by. But if everything fails, we have a different surgical alternative. We can band in the sleeve, raise sleeve, plicate, convert Roux-en-Y, and one anastomosis gastric bypass, a standard Roux-en-Y DS, a standard BPD, SADIS, SAGIS, bipartition, SASI. It's a debate. As you can see here in this session, and over, going to be a very important challenge at this time. So, but in our opinion, why to dismantle the sleeve? Because the sleeve is good, we must take advantage of it. We can maintain the antropyloric area, we can preserve the secretion on several products, we have to improve the absorption of several products to maintain some centimeter of the proximal duodenum. And we don't have biliary reflux because we have the pylorus functioning. So we published our first paper in 2014 regarding submitting the patient after failure lead to SADIS. We present this paper, we published in 2014, and here you can see how the patient at the beginning was very nice, after the leave, then worse, and then after the SADIS procedure were very nice, getting a 72% of say weight loss. Now, some months ago, we published in SOAR our updated numbers. 51 patients after failure is submitted to studies. This is the paper I'm talking about. And here you can see how, in these 51 patients, how, we can realize that the experience regarding the number, the BMI, and the total weight loss, the weight loss, 5 years after the operation, going to be mimicking the previous publication where you already did. But focus mainly what are the patients that are doing better. Here you can see the patient with a BMI less than 50, they did better. Those patients with the BMI were operating 3 years later after the sleeve are going to be much better, and the patient that lost more weight after the sleeve, they did better when they were submitted to studies after the sleeve. And here you can see the exact correlation between the better weight loss after the sleeve and the better weight loss after studies, in this figure. And the same the results have been reproduced by some other groups. This is the result from the Khaitan group in Utah, in US. The same result after the patient did well, then worse, and after studies, getting the same almost 70% exceed weight loss after the procedure. And here, let me share with you that last paper, the recently published by the Holland group, updated 5 years. And here you can see they submitted the patient to Roux-en-Y or to SADIS procedure. And here you see after the sleeve, the patient did well, then worse. And they were submitted to SADIS, the black, the most intense black color, and the gray line, the Roux-en-Y. And you can see, appreciate here, you can realize here that after 5 years, the patient submitted to Roux-en-Y after the sleeve got the same total weight loss that after failed sleeve. It's like this operation in those patients, it didn't work well. And then on the other hand, are going to be important, that realize they're going to be almost 10 to 15 points of total weight loss better in the patient after studies, submitted to studies after sleeve. This paper has been recently published in Obesity Surgery, and in the same, here you can see difference in Roux-en-Y versus the SADIS patient. And in this paper, they compare, the nutrition deficit, this concern that many surgeons have, even Dr. Cohen here, they have, they compare SADIS and Roux-en-Y. Here you can see there is no differences between those patients submitted to Roux-en-Y after failed sleeve and those patients submitted to SADIS after failure sleeve. I have to point out that those groups in Holland, they performed the anastomosis of the studies 250 from the ileocecal valve. Only 4 patients were submitted to a study procedure 300 from the ileocecal valve, meaning that the very safe procedure. Only, the less or the better, the worse result were regarding the Roux-en-Y gastric bypass, regarding the folic acid and the vitamin B12. So it's going to be no difference regarding all these studies regarding the nutritional issues. Even in the journal, they summarize in this paper showing 141 patients after the sleeve, 66 to SADI, 78 to Roux-en-Y, 5-year result. SADI resulted in more than double the amount of weight loss than the Roux-en-Y. Nevertheless, when the patient has a GERD problem in a sleep patient, Roux-en-Y is the ideal procedure, and we share with this author this opinion. We also compare the patient after failed sleep submitted to studies with those submitted to one anastomosis gastric bypass in a study we performed with the Professor Marcus Reiser and Martin Bussen in Germany. We analyzed 42 patients in each arm, 42 to study, 42 to one anastomosis gastric bypass. And here you can see 3 years after the operation, even the numbers are a little bit better for study, not significantly, but the most important is regarding the adverse effect, regarding the bile GERD, going to be 26% the one anastomosis gastric patient, and 5%, 4.8% in the SADIS patient. So it's going to be just, for the sake of time, just to show you how we perform this surgery. We don't open the leg of the patient, and we go. It's going to be very easy. We work in a non-touch area because we didn't do nothing at the sleep level. We dissect all down. We dissect the duodenum. We pass a vessel loop or a tape. and then we divided the duodenum, and also the patient is not so heavy as before the sleeve. It's going to be much more easier to count the bowel, and we mark 250 or 300 in selected cases, and we perform a very nice anastomosis, as you will see in a second. No tension, very nice, good supply, blood supply. We don't divide the right gastric artery in terms of preserving the gastric artery, and also in terms of preserving the innervation of the lesser curvature. It's going to be, allowing us to preserve the vagus nerve and to improve the physiology of this area, avoiding dumping syndrome and other consequences. And then we open that and we perform a very tension-free anastomosis. So for this, in summary, for this sleeve failure, we perform, in the short-term follow-up that is some pathological GERD structure of leaks. We prefer for sure to perform Roux-en-Y gastric bypass, but the long-term follow-up with the patient weight regain or the reappearance of the comorbidity, with for sure we prefer to perform DS or SADI, and now present time we are doing SADIs in all our patients. And so that is also an option after gastric bypass. Also as a vertical banding gastroplasty, and we are performing also gastric banding as well. So it's a nice alternative after failed sleeve in terms of weight regain or reappearance of the comorbidity. So this is our summary of the present indication of the procedure as a primary procedure in very heavy patient and in very metabolic. And after failed sleeve, in all patients except the patient is very old, we have a badly performed initial sleeve, we have to redo that, or the patient has severe GERD or a sleeve stenosis, we perform a Roux-en-Y gastric bypass. And that's all I'd like to share with you. Thank you very much, and open for sure, and all the question, the comment that you can have. Thank you, Mal. I'm going to stop sharing.
Thank you very much, Antonio. Excellent presentation. We have Dr. Amino's talk. At this time, we'll go ahead and project it. May our engineers go ahead? Dr. Amino's talk about conversion to anastomosis gastric bypass.
To be with you in this meeting. This is Almino Ramos from Sao Paulo, Brazil, and that's a big pleasure to be with you in the LIBSS Symposium. And I would like to say thanks to Dr. Sanjay Agrawal and Dr. Kamal Mahawar. Thanks for inviting me to participate. And my topic, it is strategy for weight regain after sleeve gastrectomy, conversion to one anastomosis gastric bypass. I don't have any disclosure to present here. And sleeve is the most popular procedure worldwide right now. And when we have insufficient weight loss or weight regain or a reflux, we have to think about some alternative about how we can manage this patient. So maybe we can go for just a simple re-sleeve or a conversion to Roux-en-Y gastric bypass, to duodenal switch, to SADIs, or the topic of my presentation, that is the conversion to one anastomosis gastric bypass. But when we start to having the first cases of weight regain after sleeve gastrectomy, the natural solution looks like to be the conversion to Roux-en-Y gastric bypass. So first cases were converted to Roux-en-Y gastric bypass. And we have in studies like this a very important difference when in terms of weight loss when we were converting basically by weight regain, or when we are converting for reflux. You can see that we can have much better result when the conversion was related to reflux than to weight regain. So look for the excess weight loss here. that in based in weight regain, it is about 52% and reflex to 73%. And we can have different numbers from the literature, but we can see that we can have 46, we can have 40. In general, you not have numbers here over 60%. And it's very clear since the beginning that conversion to Roux-en-Y gastric bypass would be a great procedure in order to treat reflux, but not so good to treat weight regain, as is very clear in these different studies than we have. So maybe we can go for another alternative that we can have a good result, that is the duodenal switch. You can see results of conversion from sleeve gastrectomy to duodenal switch are much better than Roux-en-Y gastric bypass. But look, few surgeons are used about doing duodenal switch. So maybe even considering that we can have excellent results in terms of weight loss and comorbidities control, some surgeons will think about a different strategy. And here we have.
So Dr. Mohit Bhandari can join with the same link.
One anastomosis gastric bypass in different studies, and you can see that we can have great results in terms of weight loss and also in control of comorbidities. So a lot of surgeons can have the preference in when having weight regain in sleeve gastrectomy to try to go to one anastomosis gastric bypass. That's a good option. So let's see. So this is a short-term study. And what we can have here, we have a comparison here regarding the result of the surgery for insufficient weight loss and weight regain when we convert sleeve gastrectomy to one anastomosis gastric bypass. Much better results when we are considering insufficient weight loss. Other study showing that when we have conversion from bands or sleeve gastrectomy to one anastomosis gastric bypass, we can have great results. Look, initial BMI 45 in the conversion, 42 in the revision after the one anastomosis gastric bypass, we can have 30. Problems, GERD. GERD could be a problem here. Pay attention for that. So another study, and this study is based in conversion from sleeve gastrectomy, but comparing patients with previous bands and without previous band, and showing that results are pretty similar even in patients that we are doing one anastomosis gastric bypass as the third procedure. Again, problems with GERD. Nutritional consequences can be a problem, but here the majority of the patients are with normal status. Again, here the comparison in between Roux-en-Y and one anastomosis gastric bypass showing much better results with one anastomosis. Complications are pretty similar. Again, much more GERD with one anastomosis than Roux-en-Y gastric bypass. Same results, better result with one anastomosis when we compare with Roux-en-Y gastric bypass. Good control of comorbidities for both, better control of comorbidities for one anastomosis gastric bypass. So in conclusion, conversion from sleeve gastrectomy to one anastomosis gastric bypass, it is a safe and effective procedure offering good additional weight loss. Weight loss results are better than Roux-en-Y gastric bypass and worse than duodenal switch and SADIs. So let's think about when we are deciding. complications are equivalent to Roux-en-Y gastric bypass. We have adequate improvement of comorbidities, but GERD can be a problem. Pay attention to GERD. GERD may be a problem and should be considering in this decision. Again, thank you very much for the invitation and your attention.
Amino, thank you very much for an excellent presentation. We'll move on to the next speaker, Rui Ribeiro from Portugal. Rui, do we have his
Hi, Mal, how are you? Okay, I have a video. I would like to run the video. It will be more effective.
Okay, go ahead.
Good afternoon, dear colleagues. It's a pleasure to be here with all of you. First of all, I want to thank my good friend Sanjay, the honorable invitation and the chance to participate in this elegant meeting. My topic will be the SASI bypass after a failed sleeve. You know well that revisional surgeries are complex and technically demanding high-risk operations, requiring well-trained bariatric surgeons and well-organized and equipped units. But in the real world, we need better outcomes, and because of that, maybe we need simpler and safer techniques with better cost-benefit ratio and with a well-balanced profile that allows good outcomes. SASI seems to meet all those conditions, in my opinion. SASI, or one anastomosis transit bipartition, is a technique that incorporates the principles of OHB with a single anastomosis and the principles of bowel bipartition from Sergio Santoro. In other words, SASI is a simplified form of transit bipartition, and it implies, because of the only one anastomosis, an increased simplicity and, of course, safety. In this technique, we perform a sleeve gastrectomy over a 36 French bougie. We begin it in 6 centimeters above the pylorus, and after that we go to the ileocecal valve and we count 250 or 300 centimeters proximal, and we perform a gastroileostomy in the anterior face of the antrum, close to the pylorus, with 2 or 3 centimeters of caliber. It can be stapled or and-sewn. This way, food will go very quickly to the ileum, promoting the secretion of the incretins and the metabolic effects, as well as the functional satiety that we desire. In the same time, we have some food in the regular jejunum, duodenum and jejunum, allowing a reduction of the potential nutritional deficiencies in the future. In the clinical point of view, there are many advantages of this kind of operation. We have a good weight loss and a less weight regain in the future. It's very powerful about diabetes and dyslipidemia control. It has just a few nutritional deficiencies in the future and a low risk of leaks and GERD reflux. We have also a less risk of internal hernia. We have no bowel exclusions, which allows a total endoscopic access to all the bowel and to the stomach. And of course, if any problem exists, it's easily convertible to a sleeve without difficulties. But we have also some disadvantages and risks in this operation. The staple line is long, and because there is some risk of hemorrhage, we usually make an oversuture of all the staple line. There is some cases of marginal ulcer because of maybe the effective bile in the bowel margin of the anastomosis, mainly in smokers, of course, like in other operations, and an increased risk of bile gastritis with unknown effects about the recirculation of that bile in the digestive tract. Just commenting on some papers about SASI, we can show this work from Tarek Mahdi, comparing SASI with sleeve and OHB in a retrospective study, and he found that SASI had a better weight loss and better diabetes control or improvement than with sleeve or even OHB, and also the same for dyslipidemia, and a better also improvement of gastroesophageal reflux. In this retrospective study promoted by Tarek Mahdi, including patients from 7 countries, including our own patients also, we found that the percentage total weight loss was about 28% But the type 2 diabetes complete remission was what in about 84% of the cases, with partial improvement in the rest of the patients. Good remissions in the other pathologies also, and a low rate of complications, 10%, mostly minor complications. In this study from Same Emil, he has got a systematic review including 10 studies with 941 patients, and he confirmed the good outcomes of the operation, with the difference that he found the difference between the 300 centimeters common limb against the 250 centimeters of common limb, with better outcomes in the first option, 300 common limbs, mainly about improvement in diabetes, hypertension, and with less complications. So we can have here the chance to tailor a little bit the procedure. The data about revisional SASI are scarce in the literature, and we found this work from Salama with 28 patients with SASI after failed sleeve. The average BMI was 45.6 also. The mean operative time 1 hour, and the mean in stay in the hospital was 2.3 days. So it seems to be an easy and safe operation. The mean BMI decreased from 45.6 to 32.1 after 1 year. We reported 5 cases of complications, but he was able to deal with it somehow easily, and most importantly, there were no postoperative leakage or mortality and no postoperative nutritional complications. So his conclusion was that SASI is a new promising bariatric surgery, effective, safe and simple revisional surgery after failed sleeve. From our own experience, we have operated 12 cases with a follow-up of 25 months. The percentage of the total weight loss was 43.8%, as you can see in the graph. We had only 1 case of hemorrhage, intraoperative complication with the conversion and control, but no early or late complications in all the patients. The diabetes improvement was 100%, the same rate for reflux, and hypertension, we have got 2/3 of improvement of the patients. So those outcomes are very satisfying, and we are thinking about to continue with this operation. And the indications for this operation will be after a failed sleep case with very important diabetic status, or patient with previous nutritional issues like iron, calcium, B12 or folate deficiencies, or anemia associated with gastroesophageal reflux. But in the end, we need more data to confirm the good outcomes and to be more confident with this kind of operation. And that was my final message. Thank you very much for your attention. Muito obrigado.
Muito obrigado. Thank you very much. And we'll go to the final presentation for the session. Dr. Mohit Bhandari from Indore, talking to us about banding the sleeve as a revision procedure. Go ahead with his video presentation, please.
A very good afternoon to all of you. This is Dr. Mohit Bhandari here from Indore in India. And at the outset, I would like to congratulate Dr. Sanjay Agrawal for this fantastic meeting he is organizing, the London Bariatric Surgery Symposium 2021. I think it's one of the most sought for meeting, one of the most coveted meeting everybody was waiting for. I'm asked to speak upon strategies for weight regain after sleeve gastrectomy and banding the sleeve. I run Mohawk Bariatric and Robotic Surgery Center, also represent Sri Aurobindo University. Mohawk Bariatric Center here in Indore in India is Asia's highest volume bariatric metabolic surgery center. It's been here for last 12 years. My disclosures are that I work with Professor Fobi, who is the founding president at Bariatric Corporation, and Professor Galvao Neto, who recently joined the position of Director of Bariatric Endoscopy Services at Mohawk Bariatric Surgery Center. Apart from that, I'm a consultant to these companies, and I leave it to your wisdom to judge my lecture in the light of my disclosures. We have done close to 16,000 bariatric procedures, and as you can see, we have done good amount of banded sleeves, which is around 1,300 plus. And I think we published a lot on banded sleeves, so I think I'll be able to justify what Professor Agrawal wants me to speak upon. Sleeve gastrectomy has become one of the most important single stage operation these days, and it's gaining popularity all across the world. But we all know that sleeve gastrectomy has that Achilles heel of weight regain at 6 years of around 50%, which is published in most of the meta-analysis. Considering that, we also know that most of these patients will also have their hypertension and type 2 diabetes coming back once they regain their weight after sleeve gastrectomy. There are several options to revise a sleeve gastrectomy, and we can discuss about that, but I'm supposed to talk about the banding of the sleeves, as opposed to several other procedures. What we did was we took a study to determine the outcome of revision of sleeve gastrectomy to banded sleeve gastrectomy for inadequate weight loss and weight regain. So this is a retrospective data which we analyzed, and obviously we had to document weight loss at 1, 2, and 3 years. So this is a primary stage operation as a standard sleeve. So you see it's a 75 to 150 cc of sleeve volume, entrectomy done anywhere between 2 to 6 centimeters. But when we converted this into a banded sleeve, we always have to reduce the pouch to further minimum, because we need to place a ring of 7 to 7.5 centimeters, 3 to 4 centimeters from the EG junction. So volume of the proximal pouch would be less than 30 cc, which is what is the principle on which we based our re-sleeves and banding. Now, if you see this particular video, this would show how we manage a weight regain after a sleeve gastrectomy. So this is a case where sleeve dilated and we had a lot of weight regain. Now we decided to dissect the entire greater omentum, which is something called as a new greater curvature, which is along the staple line. And we have to dissect this because we might want to rule out a large hiatus hernia or something. And once we put in a bougie, we see that the dilatation is more on the fundus. So we left the body, but we decided to attack the fundus and we resected it. And then perigastric space is created around 3 to 4 centimeters below the GE junction, and then this ring, this is a minimizer ring by Bariatric Solutions, and this is the ring we are using these days. This is placed, and then we fixed it with a non-absorbable suture. So this is a sleeve to a banded sleeve, and we have very interesting data. I think probably the only center in the world which will have data on this particular thing. So now let's see our data. So this was a primary stage operation. 61 patients we revised. So this was a primary, 116 kilos of weight and 43 BMI. These were the diabetes, hypertension, and sleep apnea incidents on the primary stage. But then we see that the patient lost good amount of weight. So another weight was about average 90 kilos, but it came back to 109, and this is a story with most of the sleeve patients. It's not a new story. It's always there. And then at revisions, once we revised them to a second stage, we followed them up, and our follow-up at third year was significant. Around 72% patients turned for follow-up. So you see this data, 116 kilos is an average. We went down to 90, came to 109, and then you see beautiful results here. 84 at the first year after the re-sleeve and banding, 85, and a minor amount of weight gain, it's 86. And these patients are stabilizing almost at the same weight now at the fourth year also. So this is one of the very important data, as you would see, and I have not heard of re-sleeve and banding. Very rare option, not many surgeons are doing it. So this is a very interesting data from our center. Similarly, you see this in the terms of percentage of axis body weight loss. So the nadir weight went up to 31.52, came to 71.13, and then you see the percentage weight loss at 3 years. So good resolution of comorbidities, almost 70%. 78.6% hypertension, and OSA almost 100%. So which means that the comorbidities also get better once we revise these sleeves. So we concluded that revision from sleeve gastrectomy to banded sleeve is a technically feasible and safe procedure. Banded sleeve should be one of the options after revising sleeve gastrectomy for inadequate weight loss or weight regain. The total weight loss after the revision to banded sleeve is better than the maximum weight loss from the primary sleeve. The resolution of comorbidities is slightly improved with the revision operation, though not not very significant because we saw that diabetes was almost the same, but we had good improvement in hypertension, sleep apnea. Revision from sleeve gastrectomy to a banded sleeve gastrectomy is a good option for inadequate weight loss. So thank you very much. This is our team here in India. It can be thought as a radical approach to re-sleeve and band, but all our data is coming from our prospectively maintained database, which helps us to change our practices in the light of the evidence received from that database. Again, thank you very much for inviting me to this great meeting.
Thank you very much for an excellent presentation. I would have to say we will not entertain any discussions for this session because we're running 15 minutes late. So I'll turn over to Dr. Manish Khaitan, who will introduce our next speaker.
Yeah, thank you, Dr. Sanjay Agrawal and everybody, and thank you, Dr. Fobi. So we are going to have a talk with Natan Zundel from Israel, and he is the director of Metabolic and Bariatric Surgery-A Medical Center. That is supposed to be his medical center in Israel. So he's going to talk about strategy for managing weight regain after one anastomosis gastric bypass. This surgery or that surgery, every surgery has got the problem of weight regain. So after OAGP, weight regain, what is the strategy? Dr. Natan Zundel.
Dear Sanjay, dear friends, I am Natan Zundel from Israel. I will try today to talk about the strategy for managing weight regain after one anastomosis gastric bypass. This is my conflict of interest. This is my case disclosure. I am surgeon that perform about 2/3 of my operation are OEGP and 20% revisional surgery. We know that the bariatric surgery performed worldwide is increased. When anastomosis become the third most commonly performed bariatric surgery worldwide, and OEGP is the most common procedure today in Israel. Like see here that in 2015, sleeve gastrectomy was in Israel about 80%. Today is less than 20%. In 2015, we had 0.1% for OEGP. Today, it's more than 65%. Of course, due to the large number of OEGP surgeries performed worldwide, of course, weight regain after OEGP has been reported. We start with non-surgical treatment, usually including dietary regulation, psychological assessment, and medical treatment. Revisional surgery may be necessary in a few cases. We see here that several articles has reported the result of OEGP about weight loss, resolution of comorbidity, Musela, and group. Okay, they talk about 3,000 cases, patient that underwent anastomosis between 2006 and 2015 in his study, and about 10% had some complication. OEGP results in a significant and sustained weight loss with an acceptably low revision rate and at a long-term follow-up. Despite those positive reports, some controversies still limit the widespread acceptance of this procedure. 10% patients experience late complication after OEGP. I will talk only about weight regain. And we have see that the three articles. I don't find more articles about weight regain. The articles that I found was by Lee. One was by Musela, and Kerman Saravi. He had a review, And you see here that Lee and Mosela and Karmansaravi have about 0.5 cases that needed to that suffered from weight regain or inadequate weight loss. This is very, very low number, of course. Weight regain is unfortunately a common phenomenon associated with all weight loss modality, including bariatric surgery. Weight regain after bariatric surgery can be devastating to the patient, as many of the obesity-related comorbidity that resolved with weight loss can return. Weight regain is a long-term complication after all bariatric procedure that we know. The patient must have more than 10 kilos or 20% for primary weight. And like you see here, I find about 0.5, maybe a little less, of weight regain complication in OEGB. A long-term follow-up, about 7 years to 10 years patients. I see here, El-Ansari, he talk about weight regain after bariatric surgery, not only about after OEGP, and the predictors for weight regain was old of age, male gender, high preoperative BMI, mental health issues, presence of comorbidities like diabetes type 2, hypertension, obstructive sleep apnea. Some issue may contribute of weight regain after OEGP. Of course, we can talk about the stretching of the gastric pouch, unresected fundus, gastric-regional anastomosis may be very wild, increase in hunger over time, lack of follow-up, diet and eating habits, lack of change of nutritional behavior, insufficient physical activity, sleep deprivation, smoking cessation, drugs, cardiac diseases, and other medical problems. The most common reasons for revisional surgery now after OEGP are short gastric pouch, long biliopancreatic limb, intractable bile reflux, chronic marginal ulcer, anastomotic leak, stenosis, internal hernia, excessive weight loss and malnutrition. And in few cases, we can talk about weight regain. Revisional surgery after one anastomosis gastric bypass. Okay, of course, several kinds of revisional procedures to treat postoperative complications. We can see here a publication by Carbajo that the complication, I talk about it, that marginal ulcer, gastrogastric function perforation, etc., etc. And we also he talk about weight regain, inadequate weight loss, and examples for revisional surgery. He convert the procedure from one anastomosis to Roux-en-Y gastric bypass or creation of biliopancreatic limb of 150 centimeters. She's shortening the biliopancreatic limb, repair with patch, reversal to a normal anatomy or a Brown anastomosis. About revisional surgery after OGB complication type, we talk about 4%. This is the review of Kermansari from Iran. And again, we can see here that the weight regain or inadequate weight loss, it's about 0 to 35%. And this patient, they converted duodenal switch or prolonged the biliopancreatic limb. For me, I don't find a lot of paper that talk what we can do if the patients start to suffer from weight regain. but some surgeon prefer to put a band over the pouch. It's maybe to slow the passage of fluid bolus across the proximal part of the pouch. Some surgeon resizing the pouch, okay? Who is candidate for that? Perfect candidate for resizing of the pouch. Patient that has a correctable anatomic defect, dilation of the pouch, or underwent unresected pouch. Someone who had got good weight loss but regained some weight despite perfect diet. Someone who had insufficient weight loss despite perfect diet. But if the patient does not have a correctable anatomic defect, then not good option. Possible cause of gastric tube dilation. The last fire of the stapler was more than 1 centimeter away from the G junction. Missing hiatal hernias, missing posterior gastric fold of the fundus near the G junction, creating the gastric tube too large and antral dilation. I will talk a little about the conservative and surgical options because we don't have a lot of options. The first, of course, we try to conservative treatment, cognitive behavior therapy, lifestyle modification, try dietary intervention. Some medication can help, of course, physical activity. But we are surgeon and we know that the best option for weight regain is surgical. Surgery is the best option, of course. And here, what I found, this is the option that we can have. Resizing of the pouch, I said, or the anastomosis. If the pouch are large or the fundus are unresected or the patient have fundus because he suffered from hiatal hernia, of course, resizing of the pouch can help. If the anastomosis are very, very wide, more than 4 or 5 centimeter, of course, we can resizing the anastomosis. Some surgeons prefer to insert a band on the pouch. Know a lot of data about that, but this is one of the options. Some surgeons lengthening the biliopancreatic limb length. If the patient had 100.5 or 200 meters, 200 centimeters, sorry, he can measure all the small bowel, and he can perform, he can prolong this biliopancreatic ping if the patient have more than 5 meters of small bowel. One of the options is to convert to biliopancreatic diversion DC or SADI. This is one of the good option. And today, more and more gastroenterologists use endoscopic interventions. They can resizing the pouch. They can resizing also the anastomosis. And take-home message. OAGB is an accepted standard bariatric surgery with low revision rate. Waiting for large and long-term randomized study, of course, we're waiting for that. We hope that we finally can see more and more randomized control studies about this procedure. There are a few data concerning the managing of the inadequate weight loss or weight regain after OAGB. Inadequate weight loss or weight regain may be due to gastric pouch dilation or unresected pouch after OAGB. Option and strategy of weight regain after OAGB may be conservative, endoscopic, and surgical. The management of weight regain or inadequate weight loss after OAGB mainly is surgical intervention. Thank you very much for your listening, and I want to invite you all in October 26 to 27, 2022 in Tel Aviv in Israel. to join us with the International Obesity and Metabolic Surgery Summit. Thank you again, and I am sorry that I can't be online because now I have flown from Cairo to Israel. Thank you again.
Okay, thank you very much. We're going to use the next 10 minutes to start the discussion just about weight regain after sleeve and OAGB before we go on to the next talk about weight regain after Roux-en-Y. I'll start it off by asking the panelists. I'm curious, especially for the previous talk about converting sleeve to bypass. I'm wondering whether for weight regain after sleeve, when you do the Roux-en-Y, are the limb lengths any different than the standard Roux-en-Y that you do for a primary patient? I don't know if I think Dr. Cohen is no longer on, but I'll just ask the panel that and we can start the discussion.
Yes, may I can begin with a short comment about the limb of length, about the sleeve failure or weight regain or insufficient weight loss. When I began with the OAGB experience after 2010, I decided to apply the OAGB for some sleeve with weight regain, severe weight regain. And I performed at that time the regular OAGB with a 200 centimeters piliopancreatic limb. But in those patients, I found that they were not losing enough weight. They have lost 10, 15 kilos, but they needed to lose about 30 or 40 because they were very, very, very sick and with heavy weight. And at that time, I talked with the Carbajo and with the Rutledge, and they thought, oh no, in those cases, you need to be more aggressive. They had already one operation. The metabolic effect is decreasing, so you need to go for 250, 3 meters and 350. And I've done so, even in the same cases, and it works. So definitely for me, in my opinion, we need longer biliopancreatic limbs than in primary surgery for weight regain at least.
Yeah. Definitely, I'd like to answer this question. In any form, what we have seen in our practice and what the paper says, both are correct. Any form of weight loss, even by the patient conservatively, they have taken some drugs, some pharmacotherapy, a standard weight loss procedure may not work that better in those patients, which in other patients it works. So once we are talking of free surgery, the limb length has to be longer. But you have to take into consideration about the nutritional issues which may be more potentiated after this surgery. So the balance has to be very correct. And what the balance says is that at least 400 centimeters of common channel should be there so that the patient should not have major nutritional issues. You do whatever surgery you want, OAGB, RDS, whatever surgery you want, but this is the common channel which almost all the papers says that you should have, that the patient should not go into major nutritional complications.
100% agree with you, of course, and we need to study very well our patient and the nutritional habits and the economic power to buy good proteins to feed themselves in the future. That's very important. Like it was already said by Nicolas Copinaro for the BPD operation, it's very important indeed. Even though in our practice we consider 3 meters of absorptive limb for whatever is surgery enough in our country, in Europe. Maybe, of course, in different countries it will be different.
I think the SASI debate is interesting. Are we using limb lengthening and malabsorption? Is malabsorption the goal or a side effect of what we're trying to achieve? Is it an increasing effect by running more distally down the bowel, and therefore by partitioning, can you avoid malabsorption but still have the impact on weight and metabolic complications?
Yes. I suppose there is one from Sergio Santoro. He's talking and commenting and spreading the message of the Holoilion theory. It means that the metabolic effect, the metabolic improvement of our disease in our patients, they depend on the mix of food, undigested food and bile into the ileon. And if you do 2 meters of ilion or a SASI with the 2 meters, it can be an effect. But if you do it 3 meters, it will be more effect because more L cells will be stimulated to produce the incretins that interest to the patients in order to get the functional satiety. And that's the principle. That's why I put that study showing that the SASI with 3 meters is it's more effective than 250 with less nutritional risks in the end. But I would like to comment also because one operation that was not commented, because I've told before, I began with OAGB for failed sleeve, but after that I found a percentage of bioreflex. Almino said it, 26% in one study that it has shown. So since 2013, I began to use, and it's still my main operation for failed sleeve, the diverted OAGB or long pouch gastric bypass. In the end, it's a Roux-en-Y, but with a longer biliopancreatic limb and a narrow and long pouch. And it works very good. It works like the OAGB with a longer pouch, but we can avoid completely the bile reflex effect. So, and remember that Professor Antonio Torres showed a study comparing OAGB and SADS. He had the same weight loss. The problem was, he said, the bile reflex, and you can avoid it with the Roux-en-Y gastric bypass, a well-balanced surgery, but with some adaptation in the metabolic aspect, a longer biliopancreatic limb and a longer pouch.
Yeah, I'm glad you brought up the issue of bile reflux. I had to review OAGB for the ASMBS for the position statement a couple years ago. And I think one thing that I noticed was that in the literature, the bile reflux gastritis seems to be conflated with bile reflux esophagitis. I think we'd all agree that bile reflux gastritis is not that big of a deal. It's actually physiologic. We see Roux-en-Y gastric bypass as well. I think one of the most important things for all the publications for OAGB, that's one of the problems, even in the most recent Omega study, the randomized study, is that it just says bowel reflux, and most of those actually end up being gastritis, not esophagitis. And I think it's really critical to differentiate those. It's one of the problems with the OAGB literature right now.
Yes, sure. But I suppose it was shown here that in the study in the iOmega, the learning the skills were not so good. They were not so proficient performing OAGB, and they had a lot of complications, and they considered also complications for bioreflex, for esophageal bioreflex, the esophagitis of grade A and B, which is not very correct according to the Lyon criteria nowadays.
Right.
And that's a bias.
I guess I'm curious to hear everyone's thoughts on the banding and resleeving. That was really intriguing data from India. So it looks like there's two different aspects that's there, because there's resleeve and banding. And I guess one of the concerns is obviously having a foreign object around a fresh staple line, because that's one of the concerns with banding a gastric bypass is a concern of erosion. So I'm curious what everyone thinks about that, whether that may be a good long-term option.
Yes, I need to say a common quote, but putting restriction over restriction, it seems not a good idea for me, because I'm convinced that the restriction will fail somehow in the future, and to give more restriction, it will fail more than other options. And most important issue is about the risk, the complications. The wrist sleeve is a risky operation for leaks, more than the primary sleeve, of course. And putting a band, we know that bands, sometimes I had that experience. I use a lot of bands in bypass in Roux-en-Y before 2010, and I had some complications difficult to deal with, namely the gastrogasthic fistula was associated with the band erosion. Those are very tough and risky for the patient. So I think it's not my option nowadays. I leave the rings.
Let me weigh in on that. Revision of the sleeve. It depends on what you're revising the sleeve for. The study that Mohit talked about is one we did prospectively. When patients presented with a sleeve, an upper GI series and endoscopic studies showed that they had good weight loss and had weight regain. And when we could attribute the weight regain to a dilated sleeve, and the patient did not particularly want a more invasive procedure, we offered them a resleeve and a banded procedure. We did that because we did a prospective study of the primary banded sleeve and showed that at 6 years, the banded sleeve is better than the non-banded sleeve. And so in that subsection of patients whose weight regain is due to pouch dilatation, resleeving and banding the sleeve is very effective. However, if you go into a patient and the sleeve size is small, putting a band there is doing nothing. So that is the difference. In those cases, we either convert the patient to a banded gastric bypass or to a one anastomosis gastric bypass. Go ahead.
I had one question. So I think we all talked on revisional surgery. Let us say an example of a sleeve, weight regain, converted to Roux-en-Y or one anastomosis. What if he comes back? So he lost weight again and weight regains again back to 45, 50 BMI. Would you, or how would you work that up? And what procedure would you then offer if you already done a bypass on that patient?
Well, we did some studies, and I'll tell you practically, we reviewed our revision of sleeves. And as you know, Mohit has done about 3,000 sleeve procedures, and we're showing that about 50% of them will have to undergo revision by the 6th and 7th year. So the best operation to avoid any revisional surgery is to convert the sleeve to a banded gastric bypass with slightly increased biliopancreatic limb of 200 centimeters. And that is what is showing us a 4-year better result. Because we found out that if you just convert it to a one anastomosis gastric bypass, they have excellent weight loss, but by the 3rd and 4th year, they start regaining weight. And if you just did a wrist sleeve, they will regain weight. But the other people have to repeat these studies to confirm. But again, we cannot expect 100% result. We're still going to have patients who will beat the operation. As I always end up my presentations when I talk to groups like this is, obesity is a very difficult medical problem. And the more surgeries you do and think you know it all, and the more you know, you find out you don't know much. I've had patients where I've brought the common limb down to 2 feet, and the patient is looking at me and smiling and having weight regain, and only has complication of protein malnutrition. So those patients are special.
All right,
Sure.
we're going to move on to the next talk, which is Dr. Higa, strategies for weight regain after Roux-en-Y gastric bypass. I think he uploaded his talk. If there
should be a video. It's coming up.
Yes, sir.
Thank you for the invitation. I'm sorry that I can't be with you live today for 2 reasons. One, it's our holiday in the United States. It's Thanksgiving, an important holiday. And more importantly, it's my 38th wedding anniversary. So please forgive me. The topic is weight gain after gastric bypass and the options. Here are my disclosures, and even more importantly is this disclosure because we do not have the answer for gastric bypass failures, and this problem is especially frustrating to me because it's something I've been working on for over 25 years, but it really reinforces the need to get it right the first time. The selection of the operation for the patient rather than the selection of the operation by the patient, I think, is a very important discussion to have. Our take-home messages are, number one, don't blame the patient. Compliance is not the issue here. This is a biologic disorder. It's not a psychological one, and most of the time, compliance is simply a myth. The real question we have to ask ourselves in bypass revisions is why? Why does the patient seek a revision, or why do we think the patient needs a revision? Is it mostly for weight, which is usually the case, or is it because of comorbidities? We know the gastric bypass effect continues even with weight regain, So most of the time, it really is mostly cosmetic. Now, this is not to trivialize this. This is a very important thing for our patients. But since the risks are higher and the benefits are unknown, then for a cosmetic procedure, we're embarking on something that is potentially life-threatening and highly complex. Your experience may be quite different from mine. I suggest we need to track all of our results. Results must be reported and they should be done long-term. What we've discovered is that the newer pharmaceuticals, the combination drugs, especially and the GLP-1 analogs, are really as effective or more effective than any revision we do on the pouch or anastomosis, and primarily most of our patients after gastric bypass are going to receive medical therapy and not an operation. We reserve operations for the bypass for complications of the operation, which really is a separate topic altogether. Now, the type 1 distal gastric bypass, which we'll talk about, really works well for comorbidities, works great for diabetes and lipid disorders, but really produces mediocre weight loss. Ultimately, the only answer for serious weight loss is going to be conversion to duodenal switch or SADI. But this is not a trivial operation, and I'll give you some of our results. We have to remember that obesity isn't a single disease, but multiple diseases, and we have to look at our patients in this manner. In other words, look for the causes of the weight regain other than simple anatomy. What kind of medications are they on? What else is going on in their life, and address these. We know that not everybody can be an A student. Not everybody will get 100% weight loss, and that for most of our patients, they follow, just like everything in life, a bell-shaped curve. And so the patients on the lower half of the bell-shaped curve shouldn't be considered failures. They should just be considered non-responders, and most people will be in the middle group. Now, in my early career in the early 90s, it was clear to us that the operations were categorized as either restrictive or malabsorptive, and the combination of the two, i.e. the gastric bypass, was seemingly the best operation for most. We know that this is likely not true, but the concepts still remain as far as denoting the mechanism of action, and truly the mechanism of action is now not mechanical, but centrally acting on the hypothalamus through a variety of mediators that we really don't understand at this time. So even the gastric banding, which seems to be still considered a restrictive operation, probably elicits its best response in those patients who really do well through satiety, through some unknown response for that individual patient. Now, early on, I would try many things to take on the failure of the gastric bypass, including restriction, limb length, banding the pouch, reducing the size of the pouch. I mean, this seems to work primarily. Our Fobi band patients do quite well, but as a revision, that restrictive or that band around the pouch seemed to cause a lot of dysphagia. So weight loss was produced by dysphagia, and these rings had to be removed. So the quality of life wasn't very good. We don't do this anymore. The adjustable band over the bypass actually has worked quite well too, again mediated from different, other than just restriction, but I think the long-term risk of erosion is real, and erosion of a band through a gastric pouch after a bypass is a different animal than a simple erosion on a primary gastric banding. So our experience has been okay, but this can get us into a lot of trouble. So when we look at modifying the gastric bypass anatomy, we really have to look at what is the anatomy, how is it formed, what's the size of the pouch, anastomosis, what are the limb lengths, what is the nutritional state, all of these things. And I'll just go through some of our experience here. Now, the endoscopists who have a solution to gastric bypass failures, that is creating a smaller stoma, will cite this article that there is clearly a linear relationship between weight regain and the size of the anastomosis. Now, to me, if I look at the stat in a different way and take away the red line, it proves the opposite. So a gastric stoma diameter of, say, 2 centimeters, it can have very result from very good to almost no results at all. So I think this proves the opposite, that the size really doesn't matter, and that we don't have enough data points to say this. But prospective randomized trials such as this comparison of an EEA 21 versus 25 really can tell us this different story. Now, the only way to really make an anastomosis the exact same size every single time is with a circular anastomosis, and that's why this study is so important, and the fact that it's been carried out for nearly 3 years and randomized. So absolutely no difference in overall weight loss. Registry studies are important because of nearly 100% capture, something we can't do in the United States. Here's 14,000 patients from the Scandinavian Obesity Surgery Registry. And what they found is that the only difference in the performance of the patients wasn't weight loss, but increasing marginal ulcer rate with larger pouches. So for every extra centimeter increase in length of the pouch, marginal ulcers went up 14%. And I think this is held to be true, at least in our practice as well. So we try to make a small pouch, faster emptying, better tolerated, and it's really not about restriction, but whatever effect the gastric bypass has downstream, foregut, hindgut, you can discuss that. Now, there are tendencies when you look at systematic reviews of all the data that maybe the pouch or the stoma size can be associated with better outcomes, but pretty much it's not been proven. And there's contradictory results, such as this 3-year randomized control style that looked at longer pouches versus shorter pouches, and there was a significant difference in overall BMI loss and total percent BMI loss without increased risk of ulceration. Now, we all know there's an exception. This is a patient that I recently explored for possible internal herniation. There wasn't one, but to my surprise, this patient had a pouch that was nearly the size of the original stomach. 57 years old, bypass 15 years ago. Initial BMI 65, 400 pounds, somebody we would consider doing a DS or a SATI, but this patient had a bypass, and during this time, no complications. The BMI went to 24, 148 pounds. This is excellent control with rather poor anatomy. What about limb length? Does limb length really matter in a proximal gastric bypass? Well, there are several studies I want to illustrate. First is the Ducati study that looked at the type 2 distal bypass, that is simply altering the ratio of the common limb to the Roux limb. And of course, there was no difference in overall weight loss. This next study is by Walter Pori's group and looked at data on collection of patients from some of the original ASMBS database and on analysis. The difference in the Roux limb, the alimentary limb, the biliopancreatic limb, common channel, and the ratios made absolutely no difference in their performance. And the last is a trial that looked at looked at both weight loss and diabetes resolution from UK, Rubino's group. But the differences in the two operations really was just a change in 100 centimeters of the BP limb. And although the resolution was very good, there was no difference in the diabetes resolution between the two groups. So when we look at the type 2 distalization, that is a Roux limb of 150 and a BP of 50 versus a common channel 150 and a BP of 50, we find absolutely no difference in weight loss, but there was a difference in the cholesterol, total cholesterol, and LDL cholesterol performance between the two, obviously because of the effect of diversion of the bile acids and bile salts. But once again, the results can be looked at as far as nutrition as well, and this suffered. So we looked at it in a different way. I wanted to publish at least 3-year results, and this is 100 patients followed for at least 3 years and a highly selected group of patients going after satiety and handpicked by me as being good follow-up patients. So the distal type 1 bypass is a very simple and pretty safe operation, transecting the roux limb at the JJ if the roux limb is 100 centimeters and implanting about 3 meters from the ileocecal valve. Why 3 meters? Because 2 meters was too short for our patients, and all of those patients needed to be revised for diarrhea. We had 96 patients, average age was 50, and you can see at 3 years we had a very good total weight loss at 15, 19, and 24%. But the problem is with, even though these were hand-picked, very compliant patients, we only had a 50% follow-up, and this is a real problem. We found that comorbidity resolved, especially diabetes, but we've also found that there were significant nutritional deficits that occurred. And if we compare it to our 10-year data, looking at our nutritional deficit, they're very similar. But again, this is 3-year data versus 10-year data. So I can suffice to say gastric bypass is going to produce some issues with respect to malnutrition over a long period of time, and this has to be watched very closely. You can see the operation is actually one of all the operations we do, because it's not involving the pouch, simply the small bowel. It is a rather simple operation. It's necessary to measure the entire small bowel length, because you never know if what the total length is, and we don't want to simply do this operation for bypassing another 20 centimeters or so. It's just not worth the risk-benefit ratio. So a simple end to side anastomosis of the roux limb into the ileum. I like to hand sew this because you never know if you're going to be back revising this once again, and then closing up the mesenteric defects at the end. That's very important. Now, what about patients that are much more resilient, patients who are in the super obese category with intractable diabetes, on and on? Well, this is a SADI conversion. Converting a gastric bypass to any type of DS is a big deal. So this requires putting the bowel back together again, putting the stomach back together again, recreating a sleeve, doing some sort of a duodenal ileostomy anastomosis. And because of my experience of trying to do this as one stage, I found that the real issue is the gastrogastrostomy. So even though we're very careful about the anatomy, about the blood supply, putting the stomach together and then doing this concomitant sleeve results in ischemia at the anastomosis, and failure rate is too high. So this is something I prefer to do in stages. So the first thing we'll do is actually put the stomach back together again, leaving all the blood supply, the antrum, perhaps shaving off the fundus, and then putting the small bowel back together again. Now, a lot of times this will create weight regain until the next stage can occur, which would be creating a formal sleeve and then providing the duodenal ileostomy. But I think this is still the safest way to go, but it is 2 or 3 separate operations over the course of a year, and once again, very tricky, especially if you're dealing with open gastric bypass. Now here I'm resecting the fundus because many times don't really know the condition of the vagus nerve, and I think this limits the effects of the vagotomy that the patient probably suffers automatically. And putting the stomach back together again in preparation for a formal sleeve gastrectomy really requires you bringing that lesser curve to the lesser curve and trying to make the subsequent sleeve gastrectomy look very much like a sleeve, which is very difficult to do because you're still dealing with anastomosis and crossing staple line. So these patients have to be set up for the fact that they may have ongoing problems with anastomotic strictures, delayed gastric emptying, gastric reflux, and on. And once you embark on this, it seems like it might never end. But in this case, we come back around doing a single anastomosis. Duodenal ileostomy is less complex than doing a formal DS, but in my experience, limited anecdotal experience, the weight loss is not as good as doing a formal DS, and sometimes these patients actually come back to finish off with a Roux-en-Y. Well, if that doesn't work, there's not much else we can do. So here's a patient that we follow for a number of years. Originally had a gastric bypass. The patient didn't lose very much, as much weight as they would like. Quickly regained. We tried pharmaceuticals. We tried a type 1 distalization. and then converted to a sleeve, a DS, and then modify with a re-sleeve. You can see these patients have long-term issues. One operation isn't going to cut, and sometimes we don't get it right the first time. It would have been different if we knew enough that this patient wasn't going to perform well with a bypass, went strictly to a sleeve, and then possibly DS, but we don't know that on an individual basis. So here's a patient that, once again, a very similar overall patient, followed for a number of years. But in this case, we use Qsymia, which is a phentermine topiramate combination drug. But you can see we have very good 10 BMI point weight loss over a long period of time, along with the gastric bypass, without the risk of doing another operation. So once again, going over the take-home messages, compliance is really not the issue. We need to stop blaming the patients. We need to really think about the risk-benefit ratio, track our results, use pharmaceuticals more. I still reserve most of our operations for weight. It's going to be conversion of duodenal switch, either SADI or DS, but it's a pretty big deal. And that's all I have. Thank you very much for your attention, and take care.
Thank you. That was an excellent talk. Sanjay, do we want to spend a couple of minutes on discussion, or I know it's 10:45 or 3:45?
I think we can have a couple of few minutes. Barrier link is not going to start till 4 o'clock. So yeah, we should be fine.
Okay.
Manish, yeah, thank you.
So I mean, I think this is always the biggest challenge, weight regain after bypass. And I'll just start it off by asking the group, you know, common patient that comes in, your options are putting a band. Well, obviously there's medical therapy, endoscopic therapy, a band. One thing that we didn't talk about, which is sleeve of the gastrointestinal complex over a bougie, revising the anastomosis, or distalization, or converting to a DS. So curious to hear the panelists' thoughts about if they have a go-to procedure that they feel works best, because we know this is a really active controversy.
A controversy is always a controversy. You never get a satisfactory answer for a controversy. So, but for me, always less conservative medical therapy would be better. Let's try a medical therapy with all reinforcement that you have, because any resurgery is going to come with some amount of complication. That can be peroperative complication or perioperative complications. What is the best? The cat is still to be pelted. Nobody knows. Mm-hmm. Nobody knows. You can't say this surgery will work better, or my surgery works better, or your surgery works better, or something else works better. The thing is that the patient has not lost or regained weight. Pharmacotherapy, yes, because it is safe. It gives some amount of result. Counseling, yes, I do agree with Dr. Higa completely. You can't blame the patient because it is a biological problem. It is not a psychological problem every time, and we can't keep on blaming them every time. One surgery in a weight regain patient works better. The same surgery in another patient doesn't work better. The same surgery in one patient doesn't give nutritional problem. The same surgery in another patient gives a nutritional problem. So you never know what is going to work, what is not going to work. Be more conservative. Heroic surgeries are most welcome, but the outcome is always, under question.
I'll make a comment since most of our speakers are gone already. I think what we have to do is be open-minded. We are all we're in fragments. Various surgeons advocate different procedures. The advantage I had working with Mohit in Indore is that he had a very big center. We've done about 13,000 cases in 10 years. And so I had a chance to look at follow-up of sleeve patients 7 and 8 years, one anastomosis gastric bypass 7 and 8 years, regular gastric bypass for the same period. And then I had a chance to look at some of the banded procedures for the same period of time. And what we're trying to come up with is an algorithm. I think the problem we're facing is that most surgeons do one operation and they don't follow an algorithm. If you follow an algorithm, you're going to minimize the incidence of revision. For instance, if you don't, I'm not going to tell you that a sleeve is contraindicated for reflux, or one anastomosis gastric bypass is contraindicated for reflux. But if you selectively do a gastric bypass on patients with reflux, you're going to minimize the number of patients who have to have revision for reflux. And if you selectively do patients who are severely overweight, using a one anastomosis gastric bypass or a banded gastric bypass, you're going to minimize the number of patients who need revision operation. And if you're going to selectively do patients who are super obese and do a sleeve and put a band around the sleeve, you're going to minimize it. So you're not going to bring it down to zero. But I think we have enough data, and we surgeons should use all the procedures in our armamentarium and try to minimize the failures. And we can do that. It's just that we have to be open-minded. It's just that right now, every time I go to a meeting, I have a strong advocate for one anastomosis gastric bypass, a strong advocate for sleeve, a strong advocate for SADI, and nobody's talking about the patients, the comorbidities. And then when the procedure fails because of weight loss, we say, but comorbidities were resolved. I'll tell you, after 45 years in bariatric surgery, less than 5% of the patients come to us because of comorbidities of diabetes, hypertension, and all those. They come there to lose weight because the psychosocial effects of obesity is worse than what we call comorbidities.
Thank you. Thank you for that.
I think I have a comment. May I have a comment? Manish?
Yes.
Just to pour all that Mal Fobi said, but just to take into account a summary of reflection, just to try to select properly the first operation, taking into account everything, the BMI, psychological, behavior, eating habits, and so on. Because if you indicate it wrongly the first time, it's going to be a nightmare in the future. And my second mention going to be for sure, medication will help us very much incorporating medication in this to this huge problem that is the chronic disease that is obesity. Is my final comment. Thank you.
Thank you.
I just in that, if I've got a minute, I have a slightly selfish view, and it's based on what lets me sleep at night and, what's a bit more straightforward. And so my approach to weight regain after gastric bypass includes banding the pouch, includes doing a pouch reduction, Fobi ring, and possibly lengthening the BP limb, and includes conversion to DS. Conversion to DS, as Kelvin Heegers mentioned, is technically a fairly challenging procedure, and I regard it as one of the more complex benign procedures that we do. And the concerns I have are patients who get weight regain, although the compliance issue, what level of patients. What is important is that they can be compliant with looking after themselves and making appropriate dietary choices and taking their supplements and so on. And if I have sleepless nights, it's about malnutrition in DS patients, for example. So I think that's got to be a really carefully thought out revision. If you've got concerns, putting a band around a pouch is simple, straightforward. It's quite a lot of maintenance, but you don't lose sleep over it. And I guess the middle ground is reducing the pouch, putting a ring on and so on. And I think, actually bearing in mind the selection process that you go through, that, that's a good middle ground in terms of safety, all other things being, taken into account. I think if you're going to do revision, though, you should be trying to look at mechanisms of action that differ from the first time round, or try and find a reason to patch things up. If you're trying to do something that's similar to the previous procedure, you need to find something you can impact upon. Just tightening things up or redoing it is doomed to failure, I think, in the longer term.
Yes, I think one thing that struck me the most with the last presentation was that last patient he showed, who ended up having, I think, 5 or 6 operations, including re-sleeve after conversion to DS. And it almost reminds me of the oncology, where the patient get multiple metastectomies every few years. And when I was talking about what Dr. Fobi was talking about, open-mindedness, the challenge I think we have is the insurance companies having that same open mind to cover it, because sometimes insurance companies, especially in the US, will not cover a revision procedure, or even certainly not a third revision. And I think that's one of the challenges we face, but I hope they'll be more open-minded as we go forward.
Mm-hmm.
Okay. I think, shall we call it a close now, please?
Okay, it's been a nice session.
Yeah, no, I think an interesting discussion. I think we all loved it. At least I loved it listening. So,
Thank you, Sanjay. Thank you very much.
Yeah, thanks,
thank you
everyone.
for joining us. No, thank you.
Thank you, guys.
Well,
Hope to see you very soon. Take care, Sanjay.
The next session, Bariatric link, will be starting in a few minutes, please. Thank you.